Okay, chapter 24 is the child with gastrointestinal dysfunction. We're going to start out with dehydration, but let's talk a little bit about water balance in infants and young children first. Remember, we've said children and infants especially have a higher amount of water, and that water is primarily extracellular. Remember your fluids, there's intracellular, inside the cell, and then extracellular, outside the cell. The extracellular is divided up into two categories: intravascular, so it's outside cells but inside the blood vessels, and then interstitial, which is outside of cells but inside the tissues. Remember, we also said that kids spike high temperatures, and that when their temperature goes up, their metabolic rate goes up and their water need goes up. So for every 1 degree increase in temperature, and this is in Fahrenheit, they have a 10% or a 7 ml per kilo per day increase of fluid needs. That's because they have this larger body surface area, so more skin to the amount of body they have, more chance of insensible loss off of the skin. They also have a longer GI tract compared to their body size. So if they lose fluids in that GI tract, they lose more for their body than an adult does. We said temperature and metabolic demands go together, so if you increase that temperature, you increase their metabolic needs, you increase their water needs. And in general, we also said they have a higher basal metabolic rate, which means they have a higher water need. Another problem is that they just can't concentrate urine. So if a baby gets dehydrated, they lose urine at the same rate as if they aren't. For an adult, we just concentrate our urine, preserve the water that we have. A baby can't do that, so they need to ingest and excrete a greater amount of fluids. Now, the three types of dehydration, there's isotonic, hypo, and hypertonic dehydration. We're going to start with isotonic. This would be the most common type, and this is where you lose electrolytes and water equally. Generally, the majority of this is going to be lost from the extracellular space, and of that primarily from the intervascular space. So you've pulled fluids and water and electrolytes out of the circulating blood volume, which leaves you with less circulating blood volume. If you take that to the extreme, you're going to go into shock. That's what shock is a low circulating blood volume. Because you're losing sodium and water at the same levels, sodium won't change. When you draw that serum, that plasma level of sodium, it's still within normal limits. Your hemoglobin hematocrit, however, will look high, and that's just dilutional. If you take your sample of blood and you take quite a bit of the water and electrolytes out, you're left with more red blood cells, which is what your hemoglobin hematocrit are showing. So it's dilutional because it's more concentrated red blood cells because you've taken the water and electrolytes out. Hypotonic, you could also call this hypoosmotic or hyponatremic. So if you think hyponatremic, that means low sodium. This means we've lost more sodium than water. So the electrolytes, sodium being the one we're using, but all your electrolytes pretty much, have left in excess of the amount of water. These primarily leave from that extracellular or intravascular part of the extracellular. So now think we have extra water because we've taken the electrolytes out in the circulating blood volume, which makes inside of our cells more concentrated in electrolytes, so that free water is going to move from extracellular to intracellular. It's trying to make the electrolytes balanced, so the water shifts over. This makes an even greater deficit in your circulating blood volume because now you've already lost sodium and electrolytes, and now your water has shifted inside the cells. So that's the greater circulating blood volume deficit. So this can lead to really profound shock. With this, you're going to see low sodium. Remember, we said you've lost extra sodium. Again, you're going to get that dilutional increase in hemoglobin hematocrit because you've moved sodium out and then water has shifted out. So you'll see a higher cell concentration, which shows up as a high hemoglobin hematocrit. Hypertonic. This, you lose water more than you lose electrolytes. So hyper, again, you can think hypernatremic. You're going to see a high sodium level. When you have high sodium in your blood and less is inside the cells, you're going to shift from inside the cells to that extracellular spaces, and that's just by osmosis. I don't know why there's a slash there. So you're not going to see the shock syndromes because you haven't decreased your circulating blood volume as much. What you've done is decrease the fluid inside your cells. Your cells do not metabolize well. They don't function well in that setting where the cells are dehydrated, and particularly your brain does not tolerate that well. So you're going to see neurologic symptoms, neurologic manifestations. So the cerebral changes can become permanent. This is where you'll get the irritability and change level of consciousness. Anytime you change your sodium levels, you can get seizures. But this one, of the 3 types of dehydration, this is the most serious because those changes to the intracellular fluids, your brain just doesn't tolerate that, and that can end up in permanent brain damage. Okay, so how do we diagnose dehydration? Our key thing that we're going to use is the patient's weight. Weight loss shows how much water a child has lost. So on these kids, we're going to do at least daily weights. And if they're just seen in an ER, they're going to give them some fluids. It may even be more often than daily, but daily weights for sure. Infants, 3 to 5%, and this is, we're talking about drop in weight, which is also their dehydration level. That's a mild level of dehydration. 6 to 9% is moderate. Greater than 10% weight loss, we're talking about severe dehydration. Child can handle it just a little better. 3 to 4% is mild. 6 to 8% is moderate. 10% is severe. And some of the other things we're going to assess to really determine, besides the weight, determine how dehydrated they are. We're going to look at those neurologic things, level of consciousness, how do they respond to stimuli? Are they irritable? Are they okay? We're going to look at their skin, the elasticity and the turgor, and what you'll hear the nurses talk about is doughy, that the skin seems doughy. That's a sign of dehydration. And we're going to look at capillary refill, and we're going to look at the skin color, look for things like mottling, or just they get a sort of a grayish color. It's not a true cyanosis, but you may also see periorbital, and just their face does look a little bit cyanotic and pale. So we're going to really assess their skin. Vital signs, we're looking for increased heart rate. As your blood volume decreases, you compensate for that by increasing how fast your heart moves the blood that it does have. So increased heart rate on children under 18 months, we should be able to feel a sunken fontanelle. We'll see decreased tears, and we'll see decreased urine output. If you get to the point that you're seeing a decreased blood pressure, that is a late sign, and that is a sign of severe dehydration. There's a table in your book, it's table 24-1, which lists the different symptoms, signs and symptoms you're going to see based on mild, moderate, or severe for infants and children. There was a slide on here that came from an older textbook, so I took it off, and I'm going to have you refer to the textbook because the other slide had a few differences because it was an older edition. So how do we manage it? First of all, we need a really accurate INO, and then we need really good and well-documented assessment findings of all those other things we said are signs and symptoms of dehydration. So how do kids get dehydrated? Usually it's from diarrhea. 70 to 80% of the time it's viral, and that's usually, most of those are rotavirus. We have a rotavirus vaccine out, and it doesn't cover every single rotavirus variety, but the most common, most virulent. Can also be bacterial. Things like Salmonella, Shigella, and Campylobacter are very common ones. Can be caused by parasites, and we talked about some of these in whichever chapter that was on infectious diseases, Giardia and Cryptosporidium, or by food poisoning, which is usually food that's gone bad with that's contaminated with Staphylococcus or Clostridium botulinum, which is botulism. Now, diarrhea, this is where they're losing a lot of water through that GI tract, and we said they have a big GI tract for their size, so they have an abnormal intestinal water and electrolyte transport. It stays in the GI system and it comes out. Every year, 200 infants and children die of diarrhea and dehydration in the U.S., and we're a developed country. In undeveloped countries, it's the leading cause of death of infants and children. An acute diarrhea is just defined as one that lasts less than 14 days. Kids can also have chronic problems that give them chronic diarrhea. If it's more than 14 days, we consider it chronic. There is something called intractable diarrhea of infancy. This is a syndrome where there really is no pathogen. There's no germ that causes it. Usually it started from some sort of acute infectious diarrhea, but it wasn't well managed, and it turns into an uncontrollable chronic thing that just goes on. And they can also have chronic non-specific diarrhea. This is basically your irritable bowel or irritable colon. This is what we'd call it in childhood and toddlers. Pathology of diarrhea. The pathogen invades the GI system, the GI tract, and it produces the diarrhea. Part of that is done by enterotoxins that are released that destroy the interstitial epithelial cells. Then you get inflammation of the epithelium inside the lumen of your GI, of your intestines. The organism either attaches to the cell surface or it can penetrate down into the mucosa a little bit deeper. The most serious problems from diarrhea are the dehydration, also acidosis, and then shock, which is your decreased circulating blood volume. Do we treat diarrhea with antibiotics? Well, when you give antibiotics, you kill off the normal flora of the gut. Remember, our gut works primarily by having germs in it, that E. coli that helps break down the food we eat so that we can absorb it. And when you get rid of the normal flora, then we allow overgrowth of the bad bacteria. The normal good bacteria actually keeps the bad bacteria that's already there in our GI system under control. What they're doing now with just about anybody at Children's Hospital who's on a long-term or on a course of antibiotics, they give them Lactobacillus. This is a probiotic. and I'm starting to see commercials talking about this. The probiotic encourages the